Good morning, everybody. So today's I'll be presenting on screening of prostate cancer. Now we are all managing prostate cancers, but the screening part and its controversies, it still has controversies whether to screen or not to screen. So I'll be talking about the trials which led to screening of prostate cancer. So the flow of my presentation today will be the definition of screening, the incidence of prostate cancer differences in USA and India, the arguments for the screening and against the screening, the trials conducted for prostate cancer screening, the controversies surrounding the screening, and the current recommendations. So, prostate cancer, as everybody knows, is an iceberg phenomenon. There are visible cases, there is clinical illness, and there is deaths. But the invisible cases and asymptomatic cases are roaming around, and we really do not know. And screening helps detect those invisible cases. So there was a concept of lead time. So lead time is the period between diagnosis by early detection and diagnosis by other means. The detection programs should be restricted to the conditions in which there is considerable time lag between the disease onset and the usual time of the diagnosis. That is, when we see A is a point where there is biological onset of the disease, B is the point where disease is detectable via screening, and DX is the point where preclinical disease is detected via screening. C is the critical point, and S is the point where symptoms develop. So the point between D and S can be considered as a lead time. It is usually in the preclinical phase. Now let's define what is screening. So screening is the search for an unrecognized disease or defect by means of a rapidly applied test, examination, or other procedures in an apparently healthy individual. That is, the individual should be absolutely healthy. And that is the National Screening Committee definition, which is kind of an epidemiological definition in which they say that the population should be defined, and it should be perceived that the population is at risk for that disease. And that disease is going to harm the population in the future. So what are the aims of screening? So aim is to detect the disease in early asymptomatic phase and give early intervention and management. So there are mainly two types of screenings. One is population or mass screening. That is the examination of asymptomatic people at risk in the population. Second is the opportunistic screening, which we usually do in the hospitals, that a patient has come and we measure blood pressure, but the patient has come for some other reasons. So that is opportunistic screening. The primary endpoint of both type of screenings, especially for prostate cancer, is reduction in mortality from prostate cancer and the quality improvement of the quality of life in prostate cancers. So let's go to the incidence of prostate cancers. So in USA, it is 19% of new cases of cancers. That is 1,64,000 cases were detected in 2018, and there were around 29,000 deaths. In 2019, there were around 31,000 deaths, and 2020, there were 33,000 deaths. And this has been increasing every year. If we see the Indian data, it is around 10 to 12 per 1 million population, that is per 100,000 population, which is lower than that of US. In US, it is around 90 to 100 per 100,000 population, the incidence of prostate cancer. And again, it is more in urban areas than in the rural areas. Here we see in 1999, the incidence in India was around 8, while that in North America was 92 per 100,000 population. So, is screening required in CA prostate? So, the age at diagnosis of prostate cancer, the mean age is 66. While the deaths, the average death age of prostate cancer is 80. That is, we have a 14-year period where patients live with prostate cancer. Now we see the cancer incidence in USA of prostate cancer. So from 1975, it was hovering around 100 per 1 million population. Now in 1986, the PSA got approved. As the PSA got approved, more and more cancer prostate got started diagnosing, and the peak reached to 237.5 per million of population. And it then decreased and then stabilized to around 150, and it is now slightly decreasing till 2015. So estimated new cases, this we have already seen, but the important part is, though the incidence was increasing, then started decreasing, the mortality from prostate cancer has been gradually decreasing from 50 to around 25 per million of population in the USA. So I'll now show the timeline of PSA screening. So in 1970, initially in the German government recommended annual DRE for all the elderly males. Now after that nothing happened. In 1980s, search for a biomarker for prostate cancer developed. In 1984, 1978 to 1984 saw the development of PSA as a biomarker for prostate cancer. And in 1984, PSA was approved for prostate screening. Then a widespread PSA screening started in the USA from the year 1985-1986. And then randomized controlled trials started, first in Canada, then in USA, and then in Europe. That is the Quebec is the Canadian trial, then Belgium trials, then European trials, then the American trials. And then after 2000, 2005, as the trials matured, their data started coming around 2008 to 2009. And then there was an era of recommendations. So from 1991 to 2008, there was the worldwide, the era of PSA screening. After 2008 till 2000, we can say 14 or 2017, there was an era in which everybody was against PSA screening. And from 2017-18, there has been a new new interest in PSA screening again. We will see in the coming slides how it has gone. So the arguments for testing is that the PSA test can help to find prostate cancer at an early stage. And if the result is positive and the patient undergoes a successful treatment, he has a better chance of cure and may live longer. And if the treatment is successful in early stage, and he may also be spared of the late symptoms such as metastasis. Arguments against the testing say that if PSA is elevated does not actually mean that the patient has cancer. The PSA test can also miss the cancers. An elevated PSA test may detect a slow growing tumor which would otherwise have not given trouble to the person. As we have seen, the prostate cancer is a very slow growing tumor. And the person may encounter possible complications of diagnostic testing and the treatments. That is when the patient does not require treatment, still he has got treated and he is suffering because of the complications. So what were the trials of PSA screening? So the first trial was 1988 Quebec prospective randomized control trial, which was a Canadian trial. Then was the Sweden study. Then was the European ER-SPC trial, that is European randomized trial. Then the PLCO trial, which was a massive trial in the USA. Then the Goldberg trial, which was kind of a part of the ER-SPC European trial. And then there were population-based longitudinal studies. There were 3 studies there. So let's start with 1988 Quebec randomized control trial. So it had 46,000 men between the ages 45 to 80. They were randomized and they were invited for screening. There was a screening group and there was a control group. The treatment group received PSA testing and the upper limit was 3 and a DRE. And if there was abnormal result, they had a TRUS and a sextant biopsy. There was a 11-year follow-up and there was no difference according to the intention to screen. Among all screened individuals, there were 19 prostate cancer deaths per million population, and among non-screened, there were 53.4 deaths per million population. So when we see the relative risk of dying from prostate cancer was 1.01. So in the according to the incidence of prostate cancer in screened people were more, but mortality was not that high. Mortality relative risk remained 1.01. So they said that you can find more prostate cancers, but the mortality will remain the same. Then came the Sweden study, in which there were 9,000 men, and in the screening group there were DREs and plus PSA. But PSA was every 3 years in 1993 and 1996. In screening group, 5.7% of the patients were diagnosed with cancers, and out of them, half of were the localized. And in the control group, 3.8% were diagnosed with cancer, and 27% of which were organ confined. And again, they also found that there was no difference in survival at 15 years of follow-up. Again, there was some flaw. Since PSA was not used until the 6th year of the study, we cannot say that this is a 15-year follow-up of PSA screening. Then came the PLCO study of the USA, which was published in New England Journal of Medicine in 2009. It screened, it had 76,000 individuals. The intervention was for PSA more than 4 or abnormal DRE. It had a 11-year follow-up. But the problem was 52% of the patients who were in the control arm, rather the whole population, already had PSA screening, PSA test done before they were enrolled in the study. Second, the less prostate cancers were found in the screening arm, that is 6% versus 7.3% in the control group. And 1.4% men in the initial screening were diagnosed, the majority with localized cancer, prostate cancer. They were not excluded from this trial somehow. And findings after the median of 11.5 years, they said that in the prostate cancer diagnosis was in screened patients was 9% versus control was 7.8, and mortality in screen was 0.24 versus control 0.21, which was not very significant. The mortality was not significant. The flaws, it became screening versus screening trial, because the patients who were in the control group, around 50% of the patients already had PSA screening done before that. So there was a lot of contamination. That is 44% of men. And during the trial, the PSA screening in the screen group was around 85%. So it was a follow-up. Again, the follow-up of 11.5 years was from the randomization of the patients and not from the treatment given to the patients. Then the European study, that is the European randomized study of screening for prostate cancer. It was published in 2009. It had 162,000 males. It was done in 7 countries, and it had a 9-year follow-up. And the PSA cutoff was kept as 3 or abnormal DRE. Again, the contamination was less. In the American trials, it was around 50%. Here, around 20% of the patients already had PSA done before they were enrolled in the trial. So around in the screening group, around 6,800 patients had prostate cancer, while in control group, there were 4,700 patients. And the prostate cancer diagnosis in screened was 8.2 versus control in control group was 4.8. And deaths, the relative risk was 0.8. So again, the mortality reduction was not there in the trial, but again, the incidence of prostate cancer, that is the diagnosis of prostate cancer, definitely improved in this trial. So this was one of the landmark trials. And what happened? The stage migration started happening. Initially, the prostate cancers were diagnosed very late in advanced cases and metastatic cases. There was 23% of case migration because of this screening trials going on. That is, more and more localized cancers started getting diagnosed. So this ERSPC trial is basically publishing their data at every 2 years because they are following their patients. One of the reasons they say is that 11 or 15 years is a very less time for screening of patients, because the mortality of the patients, since it is a slow growing tumor, the mortality of the patients is between 20 to 30 years. So we are still right now at 16-year follow-up. So in 2019, they have published a 16-year follow-up. And then every year, this is in the European guidelines, they say that the numbers needed to screen to detect one prostate cancer death, to prevent one prostate cancer death, is decreasing as the screening is improving. The years of follow-up is improving. That is, now we have reached a number of 570. That is number needed to screen to prevent one cancer death of prostate is 570 at 16 year of follow-up, and the number needed to treat from 27 has come down to 18. So there was a very less contamination than PLCO, but the flaw was that there were variable trigger points for biopsy. That is, and since it was 7-country trial, all the countries had adopted different protocols initially. Secondly, there was decrease in mortality in 2 countries. There was no decrease in mortality in 3 countries. And in 1 country, because of very small data, the data was quite inconclusive. So when they compiled the data, then only they did the analysis, and then this thing happened. In the Goldberg study, the Sweden, this is the methodologically the best trial, and it was published in Lancet in 2010. It has 19,000 patients. Now, many of the patients of this trial are also of the European trial. So there was some matching. They had kept a 14-year follow-up with a PSA of more than 2.5 and in more than 3.4 in 95 to 98. And the contamination was only 3% because in Sweden, when this trial started, there was no PSA screening. So there was no contamination of PSA screened people already before that. Then the risk reduction was 0.56 compared to European trial of 0.8. So, and there were three population analysis. The most common study quoted is the Tyrol study of Austria. So again, Austria did not have a PSA screening program before that. It introduced, the Tyrol County of Austria introduced PSA screening in 1988, and there was free screening since 1993. And 86% of the eligible men of that county were screened. So what happened? So initially in 1970s and 1980s, this incidence was quite similar. After the screening was introduced, the blue is the Tyrol County, the incidence, the mortality of the prostate cancer started going down significantly as compared to that of rest of the Austria. So what are the harms due to screening? So as we have seen, the patient may have to undergo a trust biopsy, or if on trust biopsy if it's detected, and even in insignificant cancer, in 1990s and to early 2000s, there was no concept of very insignificant cancers. So the patients had to undergo a prostatectomy or radiation therapy, which led to incontinence, erectile dysfunction, or stricture formations. So now comes the controversial part. There were changing guidelines at every second or third year from the US Preventive Task Force. So when initially 1991 to 2008, that was an era of PSA screening. Now in 2009, the results of the PLCO trial and the European trials got published. So the US Preventive Task Force, they recommended against routine screening in 2009. They formed a committee early. They were to sit in 2010, but they formed a committee in 2009, and they recommended against PSA screening based on the PLCO and the European trials. More highlight was given to the PLCO trials because it was the American trial. Now, one thing interesting was in the US Preventive Service Task Force Committee, there was no urologist, there was no medical oncophysician in the committee. So it was basically determined for primary care physicians. So there were all generalists in that committee. It was a committee of 14 people with a time period of every 4 years. And there was a big change in that is 2012. They said no PSA screening to be done. And it again got changed in 2017 and 18. So this controversy, they said that it was assumed by the committee. Why did they recommend it against the PSA trial? Because they said that in patients who are having high PSA, all will undergo a biopsy. And they thought that all who undergo a biopsy or are positive on PSA will need to undergo prostatectomy or radiation therapy. Again, the recommendation of D, they gave against recommendation. So recommendation was D. So what happened was all the insurance companies, they deleted the PSA screening from that data. So the patients had now needed to pay if they wanted to get the PSA screening done. So this led to decrease of 25% decrease in PSA screening since from 2008 to 2012. So what happened was in 2015, when two studies were done, they again saw the stage migration going up. The localized cancers in 2015 started to go up by 20% more. And again, the US, this task force, secondly, there were many flaws. One more flaw in the PLCO trial was that 90% of the controls had PSA testing before or during the PLCO trial. Now, this PLCO trial authors, they made two revelations after they published the initial 2009 study, one in 2011 and one in 2013, that they had some problems during that study. They changed their data and then they presented it again. Secondly, US task force did not recommend anything for the African American ancestry or the Asian ancestry who were living in the USA. So they initially did a blanket ban on PSA screening in 2008 and 2012. Also, this was led with one more thing. Richard Ablin, in March 10, 2010, he was the discoverer of PSA. He quoted in an interview that drug companies continue peddling the tests And the medical community must confront reality and stop the inappropriate use of PSA screening. This led to more controversies during 2010. But now the voices are coming up again. This is from the paper of 2020 by Van Huppel Group, and he says that we must screen for prostate cancer. So I'll come again. I'll come to the screening recommendations which are there from 2017-18 to 2020. The AUA says that there should be a shared decision making in ages 55 to 69, none for less than 40, and 40 to 54, no routine screening, and more than 70 years, if there is life expectancy less than 15, then not to be screened. Screening frequency should be 1 to 2 years. In EU guidelines, they have again information of risk and benefit. The males more than 50 years and African Americans more than 45 years, they have to be screened, and screen only if good performance status and at least 10 to 15 years of life expectancy is there. NCCN again says that there should be shared decision making of between age 45 to 75 years, and if the patient is high risk, it should start from age 40, and in more ages more than 75 years, screen only if the patient is of good health. And then there are many recommendations by American Association of Family Physicians, American College of Physicians, American Cancer Society, ESCO. They say more or less the same thing, except ESMO, which still says that population-based screening of prostate cancer should not be done. The AUA recommendations I've already told. The EAU guidelines, again, I've already told that do not subject to men to PSA without counseling them the potential risk and benefit of the screening. Offer individual risk adapted strategy for early detection to well-informed men, and offer early PSA. Now the term basically they have changed from screening to early PSA testing. So offer early PSA testing in well-informed men at elevated risk of having prostate cancer. So who? That men more than 50 years, men more than 45 years, having a family history of prostate cancer, of African American ancestry, and patients who are having BRCA2 mutation gene mutations, known mutations. So the European guidelines now say the risk stratification of should be done during early detection. That is in ages 50 to 70. If the PSA is more than 3, that should be a reflex testing. As Abhishek sir had day before yesterday taught us, what is reflex testing? Reflex testing has many things. One is MRI, one is PSA density, BRCA2 mutation, gene mutation test, and nomograms and risk calculators. If there is high risk intermediate category, then MP-MRI should be done, and then it should be categorized to periods 1, 2, 3, and 4 and 5. And then according to density and PSA density and MRI, further investigation should be done. And in low risk patients, we can avoid MRI, and then we can just follow them up. Thank you.
I'm sorry, I had to go in between. So this is very important, and we know the story. But ever since the PSA has come, no other marker have come so far.
Yes.
And we know the sensitivity and specificity of PSA is low. And if you take a biopsy guided, PSA guided biopsy, then again, take is less. You got to involve other reflex this thing. Now, after seeing the and after working here, what do you think Indian guideline should be?
Sir, as the Indian guidelines should actually come up with some threshold of PSA and prostate volume, because as we know that the Indian prostates are rather small than the American ones, and the PSA also is very varied in our setups. So there should be some standardized labs for PSA testing. That should be the PSA threshold again from 4 should be slightly reduced to 3.
We have done the
yes sir
two articles. One is published in the journal
yes,
also, and we have reduced to 2.5.
Yes sir. Yes sir. So the official recommendation should also come from the USI regarding, because at present we do not have any guidelines for prostate cancer from Indian perspective.
We can have a MPH guidelines.
Yes sir.
So 2.5.
2.5.
What else? What age would you start?
Sir, we should start early because the mean age at diagnosis right now is around 66, which is very late, and our presentations are usually T3A and more. So we should start screening the patients early. I feel 45 at the age 45 there should be a baseline PSA for everybody, and then from there on we can classify that if the PSA is slightly higher, we can screen them every 2 years or every 4 years depending on the PSA levels.
But again, as you said, if you do 45, depending upon the prostate volume, you'll have a quite variation
Yes, sir.
in the PSA. So screening bulk will be more,
Yes,
and
sir.
then negative biopsy will be more. So what could be the?
But
We
but right
can't
now,
afford to do MRI in every case. Ultrasound you can do.
yes, sir. But still, the presentation in India is very late, and the incidence is again rising only. Initially, it was around 8, it has 9, now
How
rising
much
to 12.
how much value you give it to the PSA velocity?
Uh, Sir, PSA velocity is a reflex testing. So if the PSA velocity is more than 0.75 per year, then it is very significant. He should be kept under observation, and biopsy should be taken early in those patients. 0.75 nanogram per gram of prostate uh, per year. Sorry, per year.
Uh, uh, Actually, the latest Indian Journal of Urology, which has come yesterday,
Yes,
it is online since past 7 days. There is an article from from HGPGI, actually from Dr. Anil Mandhane's group, in which they have screened 9,000 men, and it is actually a comparison between hospital-based screening,
yes,
means opportunistic screening and population-based
population.
screening, in which they say that, as sir was asking, probably one of the recommendations should be in India. It should be, that's what the article says. Actually, somebody might take that article because it goes sync with what we are talking right now, wherein they say that in the Indian scenario, it should be a combination of population-based screening with an opportunistic screening, because the awareness is not there. So I think that article you should include in your presentation because it's very relevant to what we are discussing.
I think what we should do, if that article has come only recently,
Yes, sir.
that and our own data.
Yes, sir.
The second screening, we have not published the data, but you can analyze that, and with the first one, second one, and then this one, then you can present it again.
Yes, sir.
So just to see where we can improve.
Yes, sir.
What is important at the moment, we are doing lots of prostate cancer. First thing, we are seeing lots of metastatic cancer, which we should not be seeing it. Secondly, whom we were operate, they turn out to be at least 30%, 35%, they turn out to be a higher grade than the actual they are. So